Part of our conference. Let me introduce you Dr. Mohsen Said, who will be host of the next part of our conference. Please.
Thank you, doctor. Hello, colleagues, my friend. I am Dr. Mohsen from Odessa Medical University. Thanks for our conference today in Kyiv Endoscopic Surgery course, International Associates of Biportal Endoscopy. Welcome to come to Ukraine in the future. Academic communication after the COVID. Thank you, my friends. The next topic, the next lectures. Let's welcome the speaker, very great, famous in our country, Dr. Yakov Fishenko, Chairman of the Board of Ukraine Association of Endoscopic Spine Surgery, from Institute of Traumatology and Orthopedic, Ukraine. Welcome, Dr. Yakov Fishenko.
Thank you, Professor Mohsen. So let me start my presentation. My presentation will be about my experience in implementing UBE in Ukraine from beginner to professional. More than 75% of the people between age 18 to 65 years old suffer from the back pain. About 90% population have observed lumbago throughout the life. 69% related to exacerbation of the lumbago for 5 years. Due to the aging of the population, the frequency of back pain is increasing. So I prefer in my practice, I used both monoportal and biportal, but last few years I mostly use UBE because we have a lot of advantages using this technique. So the main advantages of UBE is magnification in illumination, easy targeting point, panoramic view, less limited working space. We use for UBE 0-degree scope, natural gravity, radiofrequency, boring, selective decompression, and UBE leaf, lumbar interbody fusion. The main principles of UBE is triangulation, the water circulation. We have two points with inflow and outflow, and no natural cavity, because we need to make this cavity under the multifidus muscles, and then when we remove the part of the lamina, so our cavity is grow. So we have to make our cavity. The main advantages of UBE that we have two small incisions, low damage of muscles, low damage of spine ligaments, low bleeding, low infection rate. Even in my whole experience, I had just maybe 2 discitis and just few infection rates from all the surgeries. Small scar formation, excellent view, short term of hospitalization, and much cheaper than compared to the monoportal. So what do we need for the UBE? At first, we need the arthroscopic set, the camera, the light source, the monitor, the shaver, the RF generator, 0-degree arthroscope camera, and UBE instruments set. You can see the last model of the instrument set, which recommended by Dr. Son. The Kerrison rongers, a pituitary rongers, which you widely use in your open spine surgery. So for UBE, we have two main approaches, intralaminar and dorsolateral. The intralaminar, we can do the decompression on ipsilateral and contralateral side. From the dorsolateral, we make a transforaminal incision approach to remove the foraminal and extraforaminal herniation disc, to remove the osteophytes from foramen zone, and in L5S1 zone, we can remove the far out syndrome. Next, my lecture will be about far out syndrome. So for the interlaminar indication, the central and lateral disc herniation, the central lateral and foraminal contralateral approach, stenosis. For lateral, as I said you, that the indication I already said. So what is UBE approach? The target points is everyone have a different, because I saw a lot of surgeons provide the first incision, the upper camera incision in the middle of the lamina. I prefer to do it in the lower part of the laminar, and the second incision for walking incision 3 centimeters lower caudal, more caudal from the first one. For the dorsolateral approach, we check the pedicle points via X-ray and move 2 and 3 centimeters depending on the obesity of the patient. For if it's a big patient, so we move 3 centimeters. If thin patients, we move just 2 centimeters and make the 2 incisions on the in this part near the transversus process, and another one caudal 3 centimeters below. So when you start UBE, it's first what you should do, they find the target point, and the first target point is the low part of upper lamina. When you found it, it's much easier to work. I first start with a ref to just find this target point, and then use shaver to remove all the soft tissues for make my field more clear. So what we do, we just use both the RF and shaver on the first step of the when we start the procedure. And forming the first cavity. Almost done. So as you see, the main targets we already can find. What we have, the main problems when you start UBE, you have a bleeding, and this is the most scary thing in the UBE when you just started. You have to know the target points of the vessels. So we always compare what we see in the picture with the clocks. So 12 o'clock, 1 o'clock, 2, 3 o'clock, and 4, and until 12. So the main bleeding is on the 9 o'clock vessel, on the 7 o'clock, and the most bleeding is near the basis of SAP. On 4 o'clock, the main bleeding what you can find. So with the coagulation, you have to check the bleeding, and when you pass it, you can move. What we do with the bone resection? So when we start, first for doing bigger cavity, we need to remove the part of the basis of spinosus processus. It makes for us more space. What we do next, we remove the part of the lamina and the inferior processus, articular processus. Then we move to the lower lamina, and after this, if we need, we go to the contralateral side and remove parts of the contralateral lamina. When you pass the bleeding and remove all the soft tissues, done some bone work, you need to remove the ligamentum flavum. The ligamentum flavum consists from two parts, is a superficial and deeper part. So first you remove the deeper part from the lamina of the lower vertebra. So this video shows how we do it. We use for this curette and just remove a little part of the superficial part of the ligamentum flavum. First, we do it with curette, just separate. And then we are taking the shaver and remove this superficial part with the shaver. Using the shaver, you save a lot of time, because just in 30 seconds, you remove all the superficial part of the ligamentum flavum. The deeper layer we remove with the osteotome, doing osteotomy of the lower lamina, of the lower vertebra. So just carefully we make using the chisels. Be very careful. Do not touch the dura under the bone. So there is, we are in. And then using the Kerrison rongers, we can remove all the ligamentum flavum very easy. Using the curette, we just move a little bit this bone resection part. And then when we have a bigger hole, we can use Kerrison rongers. Or pituitary rongers, it doesn't matter. So next, first when I met the UBE technique, it was November 2018 in Istanbul. Then I visited my teacher, my first teacher of UBE, Dr. Hayati in Bursa, and I spent there 1 week, and more deeply I understand the principles of UBE. My first case of UBE I done almost 2 years, a little bit more than 2 years ago. Then I moved to Dr. San to Korea to my first basis course. And then in few months, I visited him again for advanced course of UBE. Thanks very much to my teachers, Dr. Hayati and Dr. Son. Thank them very much. And until today, I done more than 360 disc herniation surgeries, more than 150 levels of stenosis surgeries, more than 80 for dorsolateral approach, and done 16 UBE lumbar interbody fusion. So, and this is some cases where the big herniations we remove using this great technique. I am very happy to use this technique because I still sometimes use monoportal, but I'm finding a lot of advantages of UBE compare with microscoping and monoportal technique. Every week I have from 6 to 10 levels of decompression surgeries using this technique. And another case with extraforaminal herniation. You can see this part is a nerve under the ligament, and when we just move nerve with the retractor, we got a disc herniation. About complications, I think I have very good experience with the complication rate. So when I started my practice, not every one case, but I had a lot of Dura tears. Maybe first half year, I have first my 20 cases of Dura tears. With one case, I need to conversion to open surgery. From all my cases, and this is more than 360 cases, I just had 15 cases with a recurrence disc herniation. And most of them I done again with UBE technique. First cases with spinal stenosis, I also had sometimes lack of decompression. This is the young or the UBE surgeon who just starts this technique, they will have this problem, I think, that just often. But when I started to make MRI after the next day after surgery, I understand where I have my pitfalls and where I need to make more decompression. And then now I have a very nice cases and very nice results with a full decompression, a full round decompression of the dura in the lumbar spine. And I have a very bad injury of the cauda equina with radiofrequency. This patient had, after this case, not good result because patient had big problems with the paresis in the his legs and problems with the urina organs. In conclusion, the UBE is the best patient care: minimal invasive, low postoperative pain, fast recovery, low complication rate, good options for surgeons, easy education curve, and good for hospitals, cheaper than monoportal, short hospitalization term. And this is for our Russian-speaking audience. I'm inviting you to participate my satellite symposium via this link. You can now go through this link, and I will tell you about the discogenic disease of the lumbar spine. Thank you for your attention. If you will have questions, please write it on the chat.
Thank you very much, Dr. Fishinka, for lectures for this topic. Very interesting. The next interesting, wonderful presentation. The next topic, Dr. Koshi Serio. Let's welcome the next speaker, Dr. Shang Wei, People's Hospital in Shanghai, China. Shangbin Medicine Society. Its topic is UB clinical application in cervical case. Welcome, welcome, doctor.
Okay, hello, everybody. Can you see my slides? Is okay?
Yes, we can.
Everything okay? Okay, I'd like to start my talk. My name is Koichi Saito from Tokushima University, Tokushima, Japan. Today's topic is transforaminal full endoscopic decompression for lumbar spinal canal stenosis. And I'd like to emphasize this should be awake and aware condition because I'm doing this surgery under the local anesthesia. During surgery, I'm always contacting my patient. How was it? How is it? So this is safest monoportal endoscopic surgery. Okay, today I'd like to talk just only for transforaminal approach. I will never perform interlaminar. Interlaminar approach, usually we need a general anesthesia and sometimes epidural, but I don't like a general anesthesia because our scope is very small and thin. We should perform the surgery under the local anesthesia. There are two great mentors, Professor Kambin and Professor Hijikata. Because of their effort, we can perform the transforaminal endoscopic surgery. Okay, the purpose of my talk is to introduce a cutting-edge technology of the transforaminal full endoscopic decompression. Again, I'd like to emphasize it can be done under the local anesthesia. Okay, I'd like to tell you three kinds of surgery. Number one, discectomy. The second, foraminotomy. The finally, ventral facetectomy. Okay, this is a basic surgery, transforaminal full endoscopic lumbar discectomy under the local anesthesia. Yeah, first of all, please be the skillful surgeons of this discectomy. Then move to decompression of spinal canal stenosis. Okay, this is my like a landmark. This circle is disc insertion point on AP view. This is a location of Kambin's triangle. Basically, the skin incision is right here. For female, 6 to 8 centimeter from midline, and for male, 8 to 10 centimeter from the midline. I'm making a skin incision of 8 millimeter. This is a location of the local anesthesia using a 1% lidocaine. For a blue point, this is a anesthesia for the bones, and that one is anesthesia for surface of the disc. Usually, I'm using like less than 20, like 18 ml or 17 ml. I'm just less than 20. Okay, I'm using an outside-in technique. I put the cannula just on the facet bone and looking at the bone and disc, decompression starts. When I visited the Tony Yang in Arizona, USA, he said, "Bone is my friend, Koichi. Please always look for facet bone," he said. And yeah, I'm doing, me and Luke was looking for his surgery. And he said, "Bone is my friend." So always at the starting point of this surgery, please look for the bone. Facet bone is my friend and your friend. Okay, after good foraminotomy, you can remove this mass right here. This is transforaminal outside-in procedure. You can see here, this narrow foramen is got bigger, wider, so that we can avoid the exiting nerve root injury. If you are the skillful surgeons for foraminoplasty, you can take this such big fragment from outside in. Basically, the pelvis bothers you to put endoscope in the exact position, but if you perform foraminotomy, you can take it out completely. She, the female, was a golf player, and 2 months later, she returned to the golfing. Okay, take home message. If you have a good skill of foraminotomy, any type of disc herniation, even at L5S, can be indication for the transforaminal approach under the local anesthesia. Okay, second topic, foraminotomy for foraminal stenosis. Okay, this is my technique. First of all, placement of a cannula on the facet bone. This means, again, bone is my friend. Put the cannula here and see the surface of the SAP, superior articular process, identification of the SAP. Then sub-resection and removal of ligament flavum on the exiting nerve. Then finally, you can confirm the decompressed exiting nerve. This is my procedure of transforaminal endoscopic foraminotomy. See here my example. He is a professional baseball player, pitcher. He has a 5-year right buttock pain, increasing year by year. And I think this is slight foraminal stenosis at the right side. And I did nerve root block of L5. Look at this, the curve, it may be pushed by SAP of S1 here. SAP is pushing L5 nerve root here. After the block, the pain disappears completely, even though he has been feeling this pain for 5 years. I decided the tip of S1 is pushing L5 nerve root, so I did foraminotomy right here. After surgery, his buttock pain and leg pain completely disappears, and he is still be a good, active, professional baseball player now. This is take-home message number 2. Transforaminal full endoscopic lumbar foraminotomy, TELF. TLF would be minimally invasive decompression surgery for the foraminal stenosis under the local anesthesia. However, clinical outcome is not good when degenerative scoliosis is combined. In such cases, I'm always thinking about full endoscopic Kyiv, transcumbing lumbar interbody fusion. Okay. They are my great mentors, Professor Tony Yang, Arizona, and Professor Akira Dezawa in Tokyo. This is my great pictures taken in 2013 in Sapporo. We had E. Smith, Tony Yang, and Professor Dezawa together. Final topic is ventral facetectomy. What is that? This is a new concept of transforaminal ventral facetectomy. Please, you can see here for 4-5, the narrow foramen got bigger and drilled complete out. So this means the concept is lateral stenosis is here, the dot line. The ventral aspect of the dot line of the facet bone is completely resected so that we can remove the traversing nerve root. So this is ventral half of facetectomy. So I named ventral facetectomy. It is also possible under the local anesthesia. Okay, this is a procedure of ventral facetectomy. First of all, bone is my friend. Please look for the bone right here, surface of SAP. After identification of the SAP, SAP is totally rejected completely. Then IAP is exposed. Then after the total partial IAP rejection, you can see the thick ligamentum flavum on the traversing nerve root. And after we removed the thick ligamentum flavum, the decompression is confirmed. We can see here, this is nerve root. This is a pedicle. Okay, this is one example. 60 years old dental doctor. He has a central disc herniation, big one. and also lateral recess stenosis bilateral. So he had a both leg pain. Because of the severe both leg pain, he couldn't stand and walk. So he's always sitting and doing his dental doctor's job. Diagnosis is bilateral lateral recess stenosis at L4-5. And I did under the local anesthesia from right side and left side. Ventral facetectomy is performed right here and right here. Just after surgery, he said, I have no pain anymore. 5 days after the surgery, he could return to the job as a dentist. Look at the MRI before and after surgery. The dura is completely opened up after the surgery. This is take-home message number 3. Fluent ventral facetectomy would be minimally invasive decompression surgery for the lateral recess stenosis under the local anesthesia. When spondylolisthesis is combined, even slippage forward, clinical outcome is not good. So for this case, I'm always thinking about full endoscopic, trans, cambing, lumbar, interbody fusion, Kyiv. Okay, let's discuss the future gold standard for the spine surgery with 3 cases. The first case, 50 years old female, chief complaint of left leg pain. The diagnosis is 5S, foraminal stenosis. Here, the big SAP of S1 is pushing L5 nerve root. What's your plan? In Japan, gold standard is additional fusion surgery until 5S. So fusion is gold standard in my country. How about your countries? I'm not sure about Europe or Ukraine. Maybe open foraminotomy with wheels or one option, open surgery, facetectomy, and fusion. I think this is the gold standard. What's your opinion? Of course, our full endoscopic monoportal spine surgeon, we can perform it for foraminotomy. We can remove the tip of the SAP of the S1 and making a foraminal decompression. This patient was a nurse, and 3 weeks later, she returned to nurse job. It can be done under the local anesthesia. We can avoid the fusion surgery. So we can avoid, fusion surgery is gold standard. So this means we can beyond the gold standard. Okay, next one. He had history of twice of MED, and MED is micro endoscopic discectomy, like a tubular surgery. Tube surgery, discectomy first, and the second, laminectomy. So he had twice history of decompression here. And look at this. He now has a leg pain. 4-5 foraminal stenosis pushing L4 nerve root. This is pushing L5 nerve root. The pain from both nerve root pain. Here, I did a radiculogram for L4 nerve root, L5 nerve root here. After the both nerve root block, his leg pain completely disappeared. What's the plan? His surgeon recommend fusion surgery. But he said, I don't like fusion. Then he visited me. What's the plan? I think such two simultaneous stenosis of foraminal and lateral recess stenosis, gold standard is fusion in Japan. How about your country? UBE? I'm not sure about the indication of UBE. Okay, I'm a transforaminal endoscopic surgeon. First of all, for foraminal stenosis, you can see here widening, decompression of L4 nerve root by foraminotomy. Then look at this here, lateral recess stenosis is also decompressed due to ventral facetectomy. We transperineal fluid surgeons can avoid the fusion, so I think we can be beyond the gold standard. Okay, please look at the final case. 90 years old male, left leg pain. Maybe you know Japan, lots of elderly patients of more than 80 years old, 90 years old, many. So we need to do surgery without general anesthesia. So the surgery under the local anesthesia is very, very useful. He had a problem of the vascular and the pulmonary and heart, many complications. So anesthesiologist says, no more general anesthesia. Then he was sent to me. What's your plan? No more general anesthesia. What's your plan? 90 years old, poor general condition, 4-5 recess stenosis with herniation. What's the plan? I think in my country, many doctors says, oh, okay, I will send him to the pain physician. Okay. This is my strategy. This is local anesthesia, full endoscopic ventral facetectomy. Look at this. The narrow foramen got bigger. The leg pain is totally disappears. Also, I took the herniated mass out. Okay, this is the final view. Please look at this L5 nerve root. It's completely decompressed. The blue color is the disc surface. See, no more compression by bone and disc. Okay, thank you very much. This is my final take-home message. Transperineal endoscopic decompression surgery is cutting-edge technique. I think it can make the future gold standard. That should be the breakthrough of spine surgery. And thank you very much for your attention. Finish.
Thank you very much, doctor. Thank you very much. The next presentation, Dr. Asrafi Rizki Gatam from Indonesia. Please, doctor.
Okay, all right. So first of all, let me introduce myself. I am Asrafi Rizki Gatam. I am an orthopedic spine surgeon from Jakarta, Indonesia. So I would like to thank for the organizing committee and Professor Yakov Vishenko for having me here at this prestigious endoscopic meeting. So I hope I can share some of my experience in the endoscopic field. So what I'd like to share today is about endoscopic decompression of degenerative thoracic stenosis. So basically, this type of problem has already been discussed by Dr. Son earlier today. So this is just some of my experience. So I work here in my hospital in Jakarta, Indonesia. So for those who doesn't know where Indonesia is, so this is my country. So it's it's very, very big country. So near Singapore, Malaysia, so very near to China. And this is my city in Jakarta. So the red arrow that I show you. So the picture on the right side is my hospital. So as an introduction, the degenerative thoracic stenosis is very, very low prevalence with a very, very small numbers of patients. So basically the changes of the degenerative thoracic disease is very, very uncommon due to the stability of the rib cage. So basically if we see the degenerative changes, there are several things that we can look at. The first is the ossification of the posterior longitudinal ligament. The second one is the ossification of the flavum ligament, and the third one is the disc herniation. At this presentation, I would like to highlight the ossification of the flavum ligament, as this is the problem that I treat the most in the thoracic spine. So I rarely find a case of ossification of the posterior longitudinal ligament and also the disc herniation in my practice. So another problem in this degenerative changes of the thoracic spine is this is commonly misdiagnosed as the cervical or lumbar problem. So we rarely think that the pain or the problem is coming from the thoracic spine. So if we look at these changes, there's a very, very severe changes of the flavum ligament from the simple thoracic ossification to the severe thoracic ossification. So basically at the moment, the conventional open surgical technique is with total laminectomy, basically total laminectomy, either with resection of the ossified flavum or we just let the flavum over the dura, or sometimes we have to take out the dura. So, but the problem with the conventional open surgical technique is that it affects the posterior tension band with the risk of late kyphosis and future of deterioration of neurologic state. So basically we can do the endoscopic surgery with either with biportal and uniportal technique for this kind of diseases. So if we look at the evidence of endoscopic thoracic decompression, so there's only a few of literature in the PubMed. So we can see if we put the keyword full endoscopic thoracic decompression, only 17 results. And if we look closer to the ossification of the flavum ligament with endoscopic decompression, only 15 results. And if we see from the biportal endoscopic thoracic decompression, there are no literature that showing the evidence of biportal endoscopic thoracic decompression. So this is probably quite new for the endoscopic field, but maybe some of us have already been doing the endoscopic thoracic decompression, but none of us have already written about that. So if you look at the evidence, so is it adequate, the endoscopic surgery? So according to this study, they compare the open and endoscopic decompression for stenosis. Both show favorable result between both groups. So, but the endoscopic group had faster recovery. So this is another study. So we can see that full endoscopic decompression could have a good result. So they also see that there are several things that correlate with the poor outcome, such as the high intensity signal on the spinal cord, big type OFL, low ratio of the canal space area. So, and the full endoscopic decompression is also one of the reasonable options for management of the ossification of flavum ligament, but it is not for the beginner surgeon actually, but this is can be done by a more experienced surgeon. So these are my steps of doing the endoscopic thoracic decompression. So this is quite different from the lumbar spine. The first thing is we have to know the anatomy of the thoracic spine. So if we look at the anatomy, the first one is the facet joint. The facet joint is oriented more coronally compared with the lumbar spine, which is oriented sagittally. So this is one of the landmark when we first want to do the decompression. The second one is the look at the spinous process, base of spinous process and the lamina. So basically there are no interlaminar space visible on the thoracic spine. So we have to open up the bone first before we can see the interlaminar space. So I usually start from this point as my starting point for decompression. And then after that, I will start doing the hemilaminotomy I remove the lamina and the superior part of the lower lamina, and also the medial part of the superior articular process of the facet joint here. So this is the endoscopic view. First, I usually find this is the margin of the inferior margin of the lamina. So if we imagine that going to the top here is the spinous process, and then I will burr until I find the central fat. So this is one of the things that we have to consider when doing the thoracic decompression. And the second one is we have to also understand what happened in the ossification of the flavum ligament. So what happened is we have to see that this is the location of the flavum. So the red one here is the part of the flavum ligament that is ossified. So we have to make sure that this part is removed during the procedure. So this is the part that we want to remove. So usually there is some extension from the SAP here to the medial part into the canal, so covering the dura. So this picture on the right side here, this is the part of the ossified ligamentum flavum. There are part of the flavum ligament that is still intact, but this part on the lateral part, this is the ossified part of the flavum ligament. So we have to burr out the ossification, so thin down the ossification until it is thin enough that we can see the dura, so we can remove the ossified flavum by using the elevator or even using the endocarison patch. So this is the part of the flavum. And then before we do the surgery, we have to consider some of the things as a pre-op planning in this case. So because this is a very, very challenging case, the complication rate is quite high, and then the risk of deterioration of neurology after the surgery is also quite high. So the first thing is that we have to identify the epidural fat in the MRI of the thoracic spine. So we have to see here whether the patient had epidural fat or not. If there are no epidural fat, probably we have to think whether you can you want to proceed to do endoscopically, or you want to just directly do the open procedure. So because when there are no central fat, there are no epidural fat between the flavum here, the surgery is going to be very, very challenging. And the second one is we have to see the severity of the ossification. So on the left side here, this is a mild ossification of the flavum ligament, which is going to be quite easy if we do that. And on the right side here, very, very severe ossification with no central fat, no central part that is available for insertion of the instruments. And the next step is we have to evaluate whether there are coma sign or tram track sign. So this is one of the things that one of the signs if there are calcification of the dura mater, like in this picture. So this is the healthy dura, and the one on the right side here is the dura that are already calcified due to long-standing compression from the ossification. So we have also to consider that, because when there are calcification, sometimes when we remove the flavum, the ossified flavum, then we also remove the dura mater, and we will get the dural tear after it. So this is the thing that we have to consider. So the portal is just a normal one between the pedicle, the upper pedicle and the lower pedicle. Upper pedicle is the viewing portal, the lower pedicle is the working portal. So I always work from the left side for this kind of case. So I remove the, I detach the muscle over, so I will try to meet both the muscle elevator and the obturator at the center. And I would like to make sure that the water will flow smoothly, continuously before I do the surgery. So this is one of the case, male, 44 years old, with the chief complaint of white pace gait with stenosis of thoracic 11 and 12. So what I do is, this is a simple decompression of the stenosis. First, I drill out the lamina, and then I drill out until I find the ligamentum flavum, and then I drill out until I find the central fat here. So the central opening between the ligamentum flavum. And then after that, I started to take out the ligamentum flavum over the spinal canal. So this is this part on the lateral part is the facet joint. So we will have to remove the facet joint to have a full decompression. So we can already see the spinal canal here, removing the ligamentum flavum all the way until the insertion point on the cranial aspect of the lower lamina. So we can see there's full decompression of the central canal. So this is the MRI after the decompression. The space is getting big. So this is another case, female 57 years old with lower extremity weakness with ossification of the flavum ligament on the thoracic 10 and 11. So I also do the endoscopic decompression for this case. So with the same procedure, I always find the margin of the inferior edge lower lamina, do the drilling until I find the central fat. And also the most important thing is that we have to drill out as thin as possible. So so this is the central fat. So we can insert the instrument. So there are some of the flavum that is still available above the ossification. So this is the ossified part of the flavum ligament sub. So if the room is very narrow, then surely we cannot put our instrument under the ossified fragment. So we have to be very careful when we insert the instrument under the ossified fragment. So we have to thin out the ossified fragment until it's very thin, until we can insert our instrument over. So you can see that when we insert the instrument, there are a little bit of pressure over the surface of the dura here. So that is the things that very dangerous when doing the ossification of the flavum ligament. So after a decompression, so this is a full decompression state of the thoracic spine. So this is the final MRI. So we can see that there are no compression over the dura mater and the spinal canal. So also on the axial spine. So I also do, at first I did the uniportal for the thoracic decompression, but now I always do the biportal surgery for this thoracic decompression. So as for comparison, there are several things that we have to consider. First is the mobility of the instrument. For the thoracic spine, we need a good mobility of the instrument. So I think the biportal is better in this thing. And the second one is the field of view of endoscopy. So the main advantages of biportal surgery is we have very wide field of view compared with the uniportal surgery. And the third one is the clarity. So I always have a problem with the viewing clarity in uniportal surgery. So if we compare these two images, the uniportal is not as clear as the biportal surgery. So that's why I changed to the biportal surgery. And the third one is the ease of bleeding control. I think biportal is easier compared to the uniportal. And the last one is instrument investment. So we don't have to invest a lot of money when doing the biportal surgery. So this is my results of my series on OFL. I have already done 13 cases for thoracic stenosis. So mostly on the lower thoracal spine, around 9, 10, 10, 11, 11, 12. And if we see the result, the duration of symptoms and the severity of symptoms is the most important things when we would like to look for the outcome of the surgery. So when the duration is longer, then the outcome is worse, and also when it's more severe, then it is more likely to have a decrease of the neurologic status after the surgery. So complication is also happen in this kind of surgery. The first thing is incomplete decompression. At first, I don't know how to evaluate the. Probably I don't know the anatomy itself of the thoracic spine in the endoscopic view. So at this time, I thought this is the already the contralateral part. I thought this is already the facet on the contralateral part, but actually this is the base of the spinous process. So identifying the surgical anatomy is very, very important in thoracic spine and also in endoscopic spine surgery. And the second one is the thick ossified clavicle. So sometimes this can make the surgeon confused whether we already have we're already on the through corridor or not. Sometimes we think that we burn out someplace else. So the third one is we need a very, very sharp burr. So do not try doing the thoracic decompression without a sharp burr, because this is very, very important, because when the burr is not sharp, then the possibility of injuring the dura is more likely. And this is the MRI result when I did the incomplete decompression of the thoracic spine. And the next one is dural tear. Dural tear is one of the commonest complications that happen. So you can see here that on the left corner here, there are tear of the dura. Actually, we can see the myelin inside the dura. So it can be prevented by lifting up the flavum without inserting the carrium. So that's why it is very, very important to thin out the ossified fragment of the flavum. And the next one is the neurologic deficit. So it's very, very common after the thoracic decompression. So that's why we have to minimal the manipulation to the dura matter. So that is the things that I think the most important things that we have to consider when doing the thoracic decompression. So as a conclusion, the full endoscopic thoracic decompression is very, very possible for the management of thoracic stenosis. So this is one of the things that I think most of the biportal endoscopic surgeons have to manage during their practice. And the choice of uniportal or biportal endoscopy depends on the surgeons, but in my hand, biportal endoscopy serves better as the choice of management for thoracic ossification of flavum ligament. So thank you for the opportunity. So that's the thing that I can share. So I will return back to the moderator.
Thank you, doctor. Thank you very much. The next presentation, Dr. Haramanti Mahadi Fili Tranji, Green Hospital, Indonesia. Please, doctor.
Thank you for this opportunity. My name is Harman from Indonesia. And first of all, I would like to thank the committee for organizing this kind of meeting so we can share all our knowledge and our experience worldwide. So today I will be talking about advantage of using expandable cage in UBE lumbar interbody fusion. So as you know, endoscopic spine surgery has growth exponentially maybe this past 5 years. And I believe every types of degeneration, maybe now some surgeons do endoscopic surgery to infection problem also. And last year I see one surgeon do for traumatic cases also. So I believe the opportunity using endoscopic surgery is limitless. And for this time, I want to share about you between uniportal versus biportal in performing lumbar interbody fusion. Which one is better? So I believe most of all started our lumbar interbody fusion with this kind of technique, this open technique. And it came with a lot of complication, pain, infection, wound problems. So nowadays we can do the lumbar interbody fusion using endoscopic. So I believe it's time for us to say goodbye for open surgery. But speaking about lumbar interbody fusion, because we want to put some cage inside this, so we have to know what is the ideal cage for endoscopic fusion. In my opinion, it is better if you have a small cage when you want to insert it, but it can be enlarged finally when it's inside of this. So there is a cage that is suitable, in my opinion, it's like this. It can grow 3-dimensional, but unfortunately, it is not available here in our country. So first of all, before you want to do endoscopic lumbar interbody fusion, you have to know what kind of implant cage available in your country. So likewise, in Indonesia, we have basically 2 types. One is the fixed one, fixed size, came with different size. So if you measure in diagonal, it's about 16 millimeter. So if you want to do endoscopic uniportal approach, you have to have a wide working channel above around 17 mm. And then the other one is the one that can be expand. So it is smaller in diagonal, it's only 12 mm, but it can be enlarged up until 17 or 18 mm. So the first cage, this fixed cage, or I can say a regular pillar cage, I think it's not suitable for uniportal approach, but it can be used with a biportal approach. But the second cage, the expandable one, you can use it with the uniportal approach. Of course, you have to have a specialized working channel, which inner diameter exceed 12 mm. And it can also be used with biportal technique. So I wanna walk you through the step of the expanding the cage. So after you connect the cage, and you can put this jig inside the working channel, and you can expand it with a driver like this one. So I want to walk you through my journey with endoscopic lumbar interbody fusion. I started to do endoscopic surgery back in 2014. I started with a unilateral approach, transforaminal, intraminal stenosis, etc. And back on 2018, I decided to do a uniportal fusion technique. So I choose the implant that can expand because, of course, it will make a specialized working channel that is not available in our vendor in Indonesia. They only have approximately 9 millimeter inner diameter working channel. So I have to make a specialized one with the 13 diameter inner working channel. So the approach is similar, like other speaker says. We do a facetectomy, we do a laminectomy, we do a fluffectomy. But every time I do my endoscopic surgery, I always do the bony work first. So taking out the flexion ligament is after I feel my bony work is complete, then I do taking out the flexion ligament. Usually I take out the flexion ligament as a whole. So I never do a piecemeal, or I never do a small cutting of the flexion ligament. I tend to take my flexion ligament as a whole. It will save you much time, and it will save you, guide you out from the bleeding issues. So, but in order to implant this kind of cage using a uniportal technique, after removing the flexion ligament, we can insert the specialized working channel, and we can retract the nerve like this video states. So, but for me, it's very difficult retracting the nerve using a big working channel. So this is the downfall of the uniportal approach, I think, because you have to use a big working channel. But once you're inside the disc, everything it's easy. Preparation of the implant is easy. Packing the graft is easy, or inserting the cage is easy because you don't need to worry about damaging the nerve itself. And after you insert the cage, you can easily expand it under direct visualization and under eye control. You just twist it clockwise. But the downfall of the uniportal approach for interbody fusion, I think, because you have to use a big working channel, it will make you prone to nerve injury. In my series, it's about 3 out of 10 cases. And when you are using big scopes, you are difficult to see inside the disc. While using biportal, you can use a small lens and you can easily inspect inside the disc. And uniportal approach use a fluoroscopy a lot. So on 2019, I tried to use biportal approach for lumbar interbody fusion. And first of all, I did it with this kind of cage. And as you know, this kind of cage need sequential trial size in order to have the perfect size of the cage inserting to the disc. So I think if you use sequential trialing, it will make you more prone to nerve injury, because you can repeat. First, maybe you insert a 6 mm, 8 mm, 10 mm until 12 mm until you find a perfect size. This step, I think it may lead to more risk of the nerve injury itself. So but still you can put it easily, even though the diagonal is 16 millimeter. You can put the cage easy after the trialing size. So on 2020, I tried to use this kind of expandable cage. So I feel it is much easier for me in the insertion of the cage. First, biportal technique has very advantage of inspecting the end plate, preparation of end plate. You can visualize it better, like this one. If you feel the cartilage is not chopped down, you can use a burr to flatten the cartilage. And like this, if you feel the cartilage is not clear enough, you can just drill it under visualization. And the advantage of using this cage, if you just put it, it can expand it later on. So you don't need to trial, you don't need to worry about the perfect size of the cage. You just put it in and you just expand it afterwards. So it makes the surgery much easier. So after insertion, you can just simply put it and expand it like this picture shown above. So this is the result. You can see the nicely expanded cage, and I always use drain, but I put my drain on the viewing portal, so I don't do another incision. And I try to see a small study back on 2020. I do 10 using regular cage and 10 using expandable cage. And in my opinion, with expandable cage, I do my surgery faster. I have lower nerve injury complication. I have lower dose of fluoroscopy, but eventually there's no difference in pain score, return to activity, and the fusion rate. But there's no implants perfect. So there's a disadvantages in using this kind of expandable cage. So in order to expand the cage, you have to use your strength, right? So if your hands are weak, you cannot expand the cage as much. And you have to, ability to expand the cage is fully depend on the mobility of the segment itself. If you facing with a relatively fixed segment, it's very hard to expand the cage. And once you have this kind of failure, this connection used to be hexagonal shape, but for some reason it rounded up like this. So after this, you cannot expand the cage anymore, or after frequent using, the tip of this driver will break. So this some sort of disadvantages of using this kind of specific cage. So in conclusion, in my opinion, UBE is more practical in performing lumbar fusion compared to unilateral approach. And expandable cage in my hand may make UBE lumbar interbody fusion easier, but be careful when cage insertion process because it may lead to hardware failure. So I thank you all for this kind of opportunity. Hope for the discussion. Thank you.
Thank you very much. Let's welcome the next speaker, Dr. Xu Weinbeek from Dailan Center Hospital.
Okay, thank you for introduction. Good evening, Professor Fish. Thank you. I'm Dr. Xu from Dalian Central Hospital, affiliated Dalian Medical University, China. My topic is the history and the technical detail of UBE, ULBD. My PPT content 3 points. First, the history of ULBD. Second, the lumbar ULBD case by UBE. And the third is the thoracic ULBD case by UBE. I'm sorry, now I'm in the taxi. UBE means unilateral laminotomy for bilateral decompression. The indication mainly is the central stenosis or both sides lateral recess stenosis. This video is UBE ULBD. And the disc space preparation. And then bone graft. At last, a cage. So this video is ULBD. First, let's talk about the birth of ULBD. In 1995, the American doctor Polity came out the idea of ULBD. He treated 2 cases of lumbar stenosis caused by ligament flavor hypertrophy. This is the picture. ULBD, the first birth of the ULBD. The doctor believe ULBD can reduce the spine instability caused by widely laminectomy. The German doctor Spenziger formally presented the ULBD in 1997. He do the cadaver first. He do the cadaver study. From the picture, we can see ipsilateral nerve root and contralateral nerve root clearly where the ULBD. Let's see my case of ULBD. This case, 70 years old female. This is X-ray, CT show me the severe stenosis and spondylolisthesis. And the dynamic X-ray, no instability. It means the spondylolisthesis is fixed. MR means severe stenosis. So the diagnosis is first severe lumbar stenosis, grade D. Second, fixed spondylolisthesis, grade 1. Third, cord equinox syndrome. So the treatment option, PLIF, TLIF, or widely laminotomy, or BELIEF, or other. My option is, I think the spondylolisthesis is stable, no instability. So I think decompression alone is enough. No indication for fixation, for fusion. So my option is ULBD. This is the docking set. The first is the camp, beginning camp, beginning side, basement camp. This is a severe stenosis, SP base, IAP, and cranial cordial. So this case is a severe stenosis. So interlaminar window is stenosis, very narrow. This is a laminectomy with autotome or kerosene. Laminectomy. So we can see the interlaminar window is very narrow. And the ligament flavor is dark. I think it is necrosis. This is a dark ligament flavor. Let's see the separation of the ligament is very thin. We can see the adhesion clearly. In this case, no Dura tear, I think even in open surgery, this case may lead to Dura tear. So the RF hook is a good method. nodular tear in this case. We decompress both nerve road. This is exiting nerve road. Exiting nerve road. In this area, I think curate is a good method. Exiting nerve road. Traversing nerve road. This is the medial part of pedicle medial part. Ipsilateral nerve road. Ipsilateral nerve road. So we do the decompression completely. Pre-operation severe stenosis, post-operation, pre-operation, post-operation. So we do the decompression completely. Second case is a right side lateral recess stenosis combined foraminal stenosis. Compressed here. We choose the UB over top technique. UB over the top. Do the contralateral decompression. Decompression both and road and preserve the articular. No indication for fusion. This is the road, traversing the road. So we decompressed both nerve road through UB over top technique. Last case. Also severe stenosis, lumbar stenosis, lateral recess stenosis, combined a central spinal stenosis, combined foraminal FS and lateral recess stenosis. Docking set, first docking set, and let's see the basement temp BD. This is the spinal process, IAP. Interlaminar window is very narrow. First, we do the docking set is here. Docking set. We do the bone work where U root. First, cranial SP base, and then IAP. And then this SP base, then contralateral bone decompression for the ligament fluid, near the ligament fluid. This video is contralateral decompression with a diamond bird, IAP, ligament fluid. So diamond bird, no bleeding. If we use a cutting bird in this area, it is dangerous or maybe bleeding. So contralateral decompression diamond bird is good. At last, the contralateral recess decompression with a calcium punch. Contralateral recess decompression. This is contralateral foraminal stenosis decompression with osteotome. First, resect SAP tip with osteotome, and then with a curved current, we take the bone out. Curved current. So, pre-operation, post-operation. We do the decompression completely and pre-sealed both articular. Thoracic ULBD case. This is a congenital disease, combined thoracic stenosis caused by ligament failure. Talking set. First, we find the median of ligament failure and first ipsilateral decompression and then contralateral decompression near the ligament failure, across the ligament failure, step by step. And then we take the ligament failure out and we finish the decompression. So UBE is very clearly pre-operation, post-OP. Before the operation, the patient couldn't walk, and after the operation, 5 days later, the patient can walk by himself. So I'm now in the taxi. So the internet not very good. So I finished my lecture. Thank you. Thank you, Federico.
Thank you very, very much, Dr. Xuwenbing, that you find time in taxi to present us your speech. Thank you very much. The next one, we invite Dr. Adam Geno from Indonesia to present his presentation. You're welcome.